webinars for the past year until today. I'm taking over from her as Anna will be on maternity leave for the next few months. So again, thank you very much, Anna. You're not listening to this. So I'm sure you're going to know about it. Anna has created all this very nice infrastructure that has made it really, really easy for me to take over. Second announcement is that myself and today's speaker, Thanos Vouvopoulos, we have been editing an educational BCI handbook, which is soon to appear. It will be published by IOP Publisher. It's going to be an electronic book. So keep your eyes open in that. What distinguishes this book, we think, is that it is really intended not so much to present in depth the latest research, but mostly to provide an educational venue specifically for brain-computer interfaces. We have a lot of solved and unsolved exercises, so it's also useful for BCI instructors for all the BCI modules that are proliferating these days and courses. So keep in mind open for that, especially since we have quite a few students in the audience. All right, and without further delay, let me introduce today's speaker, my very good friend, Dr. Athanasios, or simply Thanos Vouvopoulos, who will be talking about embodied virtual reality feedback in restorative motor imagery BCIs. Let me read out the abstract. Over the past decade, immersive virtual reality combined with brain-computer interfaces has emerged as a promising approach for neurorehabilitation after stroke. Motor imagery, BCIs, when enhanced with embodied VR feedback, can engage motor networks in the absence of overt movement and promote neuroplasticity. This talk will highlight the research by Thanos and his colleagues on VR BCI, showing findings from experimental and clinical studies, underscoring its promise for neurorehabilitation. Let me also say a few words about Thanos. Thanos is an assistant professor in the Department of Bioengineering at Instituto Superior Técnico at the University of Lisbon, and also a principal investigator at the Institute for Systems and Robotics, acronym LASED, in the same institution. His research is at the intersection of biomedical and computer engineering with a focus on closed-loop neurotechnologies, including non-invasive BCI, neurofeedback, and neuromodulation. He integrates these technologies with virtual environments and robotic platforms to support the treatment of neurological disorders and to promote long-term improvements in health outcomes, autonomy, and quality of life of disabled people. His research has been recognized with several grants and awards, including the Best Early Career Award from International Society for Virtual Rehabilitation. And with no further delay, please, Thanos, you can share your screen and the floor is yours.
All right. Thanks so much for the kind introduction. I hope you can hear me okay, and I hope you can see the presentation.
Yes, it looks fine.
Okay, so without any further delays, because I've warned you that I might go a little bit over the time, so I'll try to be fast. So as Sinis mentioned, I will be talking mainly in the part of our research that involves the utilization of virtual reality in the context of restorative BCIs. So this is a part of research. I'm going to be introducing a little bit the topic, and I'm going to be talking about the research that we have done the last 10 or more than a little bit of more than 10 years in that context, utilizing virtual reality, and why we're using virtual reality in this context. Given that it's a talk about restorative BCIs, I'll just start with a basic introductory slide about the impact of stroke to give a little bit of a context. The stroke nowadays, it has an increasing trend, and it's still a leading cause of long-term disability worldwide. And unfortunately, over the last few years, we see also this prevalence that even younger ages, the threshold is dropping, and even younger ages are affected more and more by stroke. This has, as a result, it has a huge disrupt in the independence, the productivity, and the quality of life of people. Current rehabilitation often plateaus in the chronic phase, so there's not much. Usually, after we assume as chronic phase when the patient is surpassing the 6 months after stroke. So many patients are functionally limited in the chronic phase, and they don't have much place for extra recovery. So as years progress and the impact of stroke is worsened, there is of course an urgent need for innovative technology-driven approaches to enhance the recovery and restore function. Now, traditionally, to maximize brain plasticity, there's several rehabilitation strategies that they are usually exploited. Some of them involve the concentrated use movement therapy, where um, the therapists are actually constrain the paretic arm and they're using the healthy arm to perform this kind of training. To avoid also compensatory movement and changes of malplasticity. We have the intensive and repetitive motor training, which is quite important during the rehabilitation training. We have mirror therapy, where the healthy arm is uh, shown and illustrated through a mirror on the side of the paretic arm, and is trying to drive visually some training and try to increase some reorganization in terms of neuroplastic changes. Um, Nonetheless, it doesn't involve any closed loop component. Also, in terms of motor imagery, which is the mental rehearsal of a movement, again, the patients are having out either the visual or the kinesthetic uh, imagery of movements, and usually motor imagery is quite old technique, and it's also used besides rehabilitation, was also used for many years, even in sports sciences uh, and in sports. So these are kind of techniques that they have been used for more than 20 years. And in the last few years, we have also the component of virtual rehabilitation, where you can see here, there's certain games that they are controlled, they interface the paretic arm with a game, and on the patients, they're called to use their paretic arm for training and play the games. Now, from all these traditional rehabilitation strategies, you can see kind of a pattern, of a trend appearing. So what we can immediately observe is that most of these cases, uh, we need the actual physical movement from patients. So these therapies depend on the residual movement of patients, limiting the options for the severely impaired patients. Mirror therapy cases are like the mirror therapy of the motor imagery. That sensory motor loop is incomplete. They're just passively receiving the feedback. And finally, in vitro rehabilitation, again, it enhances the adherence to the treatment. Nonetheless, it still relies on overt motor output. So here we see that how do we actually train for those who lack the volitional movement? And being a BCI lab, I guess you know the answer. And I don't want to traditionally introduce what a BCI is, but just to give the context how a BCI works in the rehabilitation domain, I've kind of adapted this conceptual model from Wolpal, that although it was initially designed for spinal cord injury, this version is adapted more for the stroke lesions. With the stroke lesions, we'll have between, depending where the stroke lesion could be, it will be between the cortex and the motor neurons. And what the BCI is bypassing the central nervous system, and it actually provides a pathway for the efferent motor command to reach uh, the affected arm, and is actually one of the few cases where we can try to reconnect the intention with the action. So this is possible by bypassing the central nervous system and utilizing the BCI. In traditional rehabilitation, it's always needed the peripheral manual manipulation from the therapist of the skeletal muscle system. Nonetheless, this is mainly stimulates the afferent sensory pathway. So this is passively the therapist. It actually tries to move the hand and train this skeletal muscle system. So uh, nonetheless, the BCI-driven activation of the skeletal muscle system in a closed loop neural engagement engages the efferent motor pathways. And this is an example of Simi's work, um, where we can see the contrast between the traditional rehabilitation and how restorative BCIs are actually have a really increase the premise of reconnecting this intention to action loop that is disrupted by the lesion. Um, we've seen that restorative BCIs, they're here for quite some years. So we have seen a lot of evidence on the efficacy and the impact of these studies and these systems. Nonetheless, we have a huge variability in these studies. There are different inclusion and exclusion criteria. We have different setups, different BCIs, different signal processing methodologies, machine learning methodologies, and protocols. So it's quite huge the variability, and accounting for the publication bias, we probably see those that they were mostly successful. So overall, the current limitations that I want to highlight for this talk, they're in line between they have to do with the training and the calibration of these BCIs. Usually, we might need weeks or many months to have someone to master a BCI. It can be considered as a skill for someone to learn to volitionally modulate their brain activity or control the BCI in a closed neurofeedback loop. It's kind of a skill, so it needs many weeks or if not months of training, which we don't have this luxury of time when we're dealing with patients suffering from stroke. That results, of course, for BCIs to be very mentally exhausting and increases the user fatigue. And finally, in terms of the feedback design, we know from learning sciences that poorly designed feedback can hinder skill acquisition. The same applies in BCI training, and of course, um, we have inherited much of the feedback that we're using in motor imaging BCIs in the last 20 years. I think it was also inherited by the type of feedback that we provide in biofeedback or neurofeedback kind of systems, which is a kind of a typical simple bar or arrows, which will show an instruction, with instructional feedback, and it will just show a little bit of knowledge of performance, if we're doing well or not, just to train uh, our brain patterns and learn to perform the neurofeedback. Okay, but this is, again, it was inherited from many years of neurofeedback research, and then it entered in the BCI world. Um, Nonetheless, our question was how we can utilize immersive VR environments to offer a solution in at least most of these current limitations that we have when we try to translate restorative BCIs from the lab into the clinic. So for that, I want to give just a brief introduction of what are the benefits of VR and the psychophysics behind VR. So VR uh, is surprisingly is mostly used for research than in entertainment, and there's a reason for that. VR, it provides a very the best test bed for psychophysics and to use stimulation to manipulate uh, behavior and induce physiological responses that they're quite similar to the real physical world. So VR, and that's not by mistake that VR was many years successful in the fields of exposure therapy. So um, so VR it actually provides this controlled sensory feedback where we can have this simultaneous visual, auditory, and haptic cues. We can provide sensory motor contingency where the visual feedback is temporally and spatially congruent with the user intention. We can induce the illusion of embodiment and agency, so we can trick the brain that the virtual body that they might be using is part of their physical body. We can, of course, we can provide this virtual perspective, first-person perspective, that we can enhance this illusion. And we have, of course, being digital, and we can have this motivational and affective modulation, which these immersive environments can increase the engagement and the reward processing. By gamifying the training tasks, of course, we can also increase the adherence to the treatment of patients. Here's an example of how we can actually use the virtual reality feedback, where in the physical world, in the real world, you see the paretic arm is suffering from high levels of spasticity. The patient cannot volitionally move the arm, and if they move the arm, most of the times they're performing compensatory movements. They're using more of the trunk or the shoulder, which could potentially, it's high risk of resulting into malplasticity. So we want to avoid that. As now in the virtual environment, we can render a healthy representation of the virtual limb, and in that virtual environment, we can the movement of that uh, virtual limb is triggered by the BCI, the motor command from the BCI in a closed loop. So in VR, now this perception becomes stimulation. As I previously mentioned, we can alter behavior, we can induce neurophysiological responses by providing these stimulations through these virtual environments. And we're turning this sensory illusion hopefully as a driver of neuroplasticity. This is our main hypothesis. Now, to achieve this, I want to just briefly, since I'm going to go a little bit back in time, and maybe nowadays we consider VR something that is quite common, given the low cost and the ubiquity of these devices nowadays. Nonetheless, to have these effects taking place uh, in the real world, the effects of VR in psychophysics, we need first to have the real technology to be able to render these virtual environments. And what we actually need is advanced tracking and is used as a catalyst for the effective VR immersion. So to achieve this is not just by using any type of virtual environments. I mean, 30 years ago, we still had virtual reality technology, but it wasn't still there and realistic enough to induce these changes. So what we actually need is we need for VR to work, as I said, we have to have immersion. It requires precision. So in simple words, we just need the VR system to provide a low latency to maintain this sensory motor synchrony. We need to have, of course, it needs to be rendered in a 3D environment to have a first person perspective in order to support the embodiment and the agency. We need to have some kind of haptic or vibrotactile feedback to reinforce these proprioceptive cues. And of course, we need to have very high accuracy, very high spatial accuracy and low jitter when we're actually tracking the head and the body. This will help also avoiding cyber sickness. So we need to have stable frame rates above 90 hertz because in the past, especially, we had a lot of cases of cyber sickness where my eye says that my body is moving, but yet again, my vestibular system says, okay, my body is staying still. So I have this um, decoupling between what I see and what my vestibular system is sensing, which resulted to nausea and this what we call cyber sickness. So obviously, for VR to work, we need to have advanced tracking. And I wanted to take you a little bit back in time. I want to show you this figure where with a line, I just rendered the cumulative number of publications about virtual reality over the last almost 30 years. And with bars, we see the new VR headsets that the cumulative amount of new VR headsets that they're out in the market per year. And in the top, you can see the average cost range of these devices between these different periods of time. Now, if we do a little bit of detective work, and if I show you only these figures, you might start seeing something happening. So an event probably happened around this time period here, which evoked a response. Okay, if we see it with the EEG terms, we might see probably an event happened in the world around that time. And we see that in terms of publications, the rate of change, it increased, so it's gone more sharply. Increased the number of publications in VR. And then we see all of a sudden the amount of new VR headsets after 2014 or 15, it really started to go 10 times more than on average that we had before, 20 years before that. So just to give some context, because we take maybe VR today as something granted, given the ubiquity that we currently have, but this is really started a few years back, right? Roughly 10 years back. And during this time point, we also see the price range that it actually reduces quite a lot. So what had actually happened around 2013, we had the first immersive commercial, low-cost commercial VR headset reaching the market. Also, initially, the developer kit was for labs and for developers. These generated a response to the market where after 2013 we had this huge development in VR technology. Of course, we had in the back, and this is also a time before, like in the beginning of the 2000s, until the end of the 2000s. I was also a university student. I was primarily studying virtual reality, so I quite vividly remember how primitive the VR technology was back then. And we didn't have anything close to what we have today. And of course, all the virtual reality systems that we had back then, they violated all the principles that I listed before about the sense of embodiment, immersion, and accuracy that we have today. Um, so we had something that probably it was some kind of a VR winter that we experienced in the past few decades. Um, in the field of BCIs, of course, we had in the mid of the 2000s one of the first applications, one of the first projects that they're quite famous on using VR was through the Presencia project, the European project that if Ryan is here, he will probably remember quite well, that they actually was one of the first cases, but proof of concepts where BCI was used in a virtual environment. Nonetheless, as you can observe, this is not a head-mounted or immersive virtual reality system. It's most of a cave system where uh, the virtual environment is back projected on these panels on the walls, and of course you have only three, maybe yeah, only three walls projecting the virtual environment. And being 2007, you need a lot of computational power. You need one graphics card per projector in order to be able to render synchronously and without much lag, although the lag was quite a big problem back then. So it's quite far with what we have today. So um, obviously, what the major limitations, although it's considered a VR system, it's a cave VR system, it lacked of immersion. There's no embodiment or agency, so it's just you can see your physical body but not a virtual body. It suffers from high latency and lag. It has a high computational cost to render all these 3D graphics. And of course, this is at the lab at UCL. It's not something that everyone can have at home. And it wasn't designed for stroke. It was mainly for, I think it was for wheelchairs. So just to give a little bit of brief context, how the VR environment was in the past decades, and how also if how these was also reflected in BCI research. So truly immersive VR was not yet tested in terms of BCI and the BCI domain. So this is where our research starts, where we actually started using the first immersive VR system and integrate it with BCI training. Um, so being in stroke, of course, we selected a motor imagery kind of paradigm, and we wanted to use this holistic approach in motor imagery training, where, of course, we replaced the traditional bars and arrows training with the rendering of the virtual arms. Now the cue is given by embodied feedback. So you have the arm moving, so you have motor imagery and motor observation, and not just a cue for indicating when to perform your mental strategy. Um, and back then, of course, here you can see the vibrotactile, the haptic feedback was custom made, given that the first prototypes that didn't even have controllers and trackers. So what we wanted to achieve, we have this now a system, and it was right after 2013 with the first VR systems, where we want to have a good first chance of having a visual, auditory, and haptic feedback in motor imagery training. We wanted to have increased ecological validity, so we rendered a real-world scenario. It was a rowing task. Of course, it could be any type of task, but then we're limited by the capabilities of the BCI. We're limited from the degrees of freedom that we're getting from a BCI system. And of course, uh, having guidelines from the rehabilitation domain, we went for a scenario that it actually tries to train proximal movements. That's why we have this continuous movement of the shoulder, more of training proximal movements instead of distal movements, which is prioritized in rehabilitation. And of course, being a virtual environment, we integrated it was motivational mechanisms where it had scores and level progression. So this is kind of a first case where we have a gamified version in motor imagery training. And it was also enables this technology to have this. We try to increase the usability level, where we try to render it in tablets and portable VR systems from like the Google Cardboard. So we wanted to have a prototype that could be easily uh, used in the clinic or at home if needed, and of course panels for therapists to be able to control all these different parameters, because now we have a totally different kind of training and we have totally a different control in the parameters that we can actually adjust in the MI training. Um, so a little bit fast forward, for the last years, we just tried to quantify and see what is the impact of the immersive VR training that we can deliver in the motor imagery training scenarios. And over the years, we've seen consistently impact in terms of the brain activity, initially on the ERD, on the EEG side of things. So we can see uh, when we utilize embodied virtual reality in the first person perspective, we can help participants. This is technically motor imagery, motor observation. So we drive the the imagery and the mental strategy of the participants by rendering this visual feedback in the first person perspective. We help them have not just vivid imagery, but this visual uh, drive of the movement and instruction of the movement, which helps them in response to that, their ERD and the sensory motor rhythms uh, to uh, to decrease in that case, to be more lateralized and more stronger ERD. And especially when we only have the haptic feedback, we see a stronger ERD happening. So when we were testing all these different configurations, that's the work of my student Diogo, he actually found that the best configuration for inducing the strongest and the most lateralized ERD is the combination of a head-mounted display in a first-person perspective and having delivering also haptic feedback synchronously with the movement. We went a step further. We wanted to see this embodied feedback inside the scanner. So we rendered the same feedback with a coil-mounted display inside an MR scanner, and we compared abstract feedback with just the cues, with for left and right arrows, versus the embodied feedback that we rendered through the virtual arms. Um, Although we could see activation in M1 in both conditions. In the condition when we render the embodied feedback, of course, we see more areas on the brain activated, stronger cortical activation. We see a lot of the visual, occipital lobe here, of course, given that we have a lot of movement taking place. Nonetheless, we found that we could also activate, as opposed to the abstract MI, uh, parts of the brain that we've seen on the literature that they are overlapping with what we call the mirror neuron system and the mirror neuron network, um, that it was originally found by the Rizzolatti and in macaque monkeys, and later had been seen and have proofs in humans. And this mirror neuron system is quite useful for us because we could utilize it as an alternative or additional network for neuroplasticity. So it was a quite interesting finding. Nonetheless, it's a very expensive in terms of setup and time and money to run huge studies in an MR environment. Nonetheless, this is something that we would like and we are currently continuing doing. So in summary, we just seen quite many proofs about the impact of VR training of this embodied feedback in both EEG and fMRI. Now, in terms of classification accuracy, quite from early on, when we integrated VR in our system, we've seen that, especially when we prime the motor system in virtual reality, and when we are performing afterwards, we have a training with embodied feedback, we can increase the classification accuracy. We don't change anything in terms of the signal processing or machine learning methods. Only by changing the feedback, only by delivering this embodied feedback, we help the brain, let's say, induce more clear and consistent brain activity and more clear features as a result that help then the machine learning layer discriminate easier between the two classes. So that is a nice example of how the feedback in this closed neurofeedback loop system that we have, it actually helps this this information propagates to the different layers of signal processing and machine learning, and it helps how the feedback itself, it helps the machine learning layer perform better. So that's and lastly here we run also an experiment with elderly participants that they were age matched to our stroke group that we had recruited at the time, and given the different maybe physiological differences and responses that we will have in different age ranges. So we hypothesized that also maybe there might be an impact on the reduced TRD. Nonetheless, we still participants that they were on average 70 years old, and they have never used BCI, they have never used VR before, and they've done only one BCI training for each condition. We helped them actually induce lower ERD, and also it helped on better BCI performance. At least we've seen that for first-time users, was actually quite a big augmentation. In terms of the clinical outcome, we started was around 10 years ago with the first pilot, where we recruited our first patient, and the patient ran for 4 weeks of VR BCI training with just a standard typical left and right motor imagery. Before and after the intervention, we ran fMRI scanning, and inside the fMRI, we rendered again the same training feedback for left and right arm movement. And we had a follow-up assessment 4 weeks after the end of the intervention, where again we acquired the clinical skills and the brain imaging data. So this is the training, where it was again pretty primitive at the time. It was the first immersive VR headset, and we even had to do a custom module for the haptic feedback at the time. In terms of clinical skills, we had an improvement and above the minimally clinically important difference in terms of the clinical skills. This is the Fugl-Meyer scale, where before and after the intervention there was a jump of 9 points, and that it was maintained after the intervention. Now, these changes in the clinical skills, that was also reflected in terms of brain imaging, where before the BCI training, there was no significant activation when the patient was performing this MI and motor observation inside the scanner. As after the intervention, we see the recruitment of primary motor and supplementary motor areas. And this recruitment was sustained also after the intervention on the follow-up. So it was a quite good positive first pilot. Of course, it was only one patient. We didn't have a control group. We have increased our sample size. We have mixed results. Here's an example of all of this is around the sample of 16 patients to date that they have used the same protocol with the VR BCI system. Most of them performed well. Nonetheless, we still have cases that they didn't have improvement, or they even did worse afterwards. So we have this kind of mixed results. Nonetheless, in the latest study that was run by my student Monica, they actually integrated, they used TMS neuromodulation before the training, and then coupled together with the VR BCI training, we could see a quite big, this is a sample of 20 patients, we could see a quite big increase on clinical skills. So we are quite confident, and based on what we've seen from our studies, we've run it also with TBCS and TACS, not in patients yet, but also from other studies in the literature, that I think the neuromodulation aspect coupled with embodied feedback, it really has the neuromodulation, it really has an augmentative effect. I think I really believe that neuromodulation is the way to go. So far, what I've talked about and what we've seen in the literature, we talk about embodied feedback. We talk about feedback that we render in the first person perspective of a virtual body. So this we usually characterize it as embodied feedback. Nonetheless, this is not quite accurate description. So when we talk about embodied feedback, we assume that the subject is embodied to the virtual avatar. Most of the studies, including ours in the past, they were actually testing and assessing if the participant was embodied to the avatar after the intervention or after the experiments. Nonetheless, up to date, we never had this case where we first make sure that the subject is embodied to the avatar, and then they're actually going into the perform the training with a BCI. So we need first to bring them into a level of embodiment, make sure that they're fully embodied, and then do the embodied BCI training. For with that in mind, my students Katerina and Daniela, they hypothesized that okay, if we increase induce the sense of embodiment before the embodied training, that will help the participant induce stronger ERD and better classification accuracy because we will have helped them. They will be more embodied, and we take out the risk also of those cases that they're not embodied, and we have mixed results and mixed cases in our sample size. For that, they designed an experiment where first we make sure that we embody the participants, and to do that, we first induce the visual proprioceptive triggers, which make sure that the virtual body matched the person as much as possible, and it's on a first person perspective. Secondly, we induce the visual motor triggers where the virtual body is moving in synchrony with the physical body movements. And finally, we introduce the visual tactile triggers where the virtual hand illusion. So we have the virtual body is struck synchronously for a paintbrush to give this tactile stimulation synchronously with a physical body. So this comes back to the years of the phantom limb illusion, the rubber hand illusion. So those studies that have done previously in neuroscience about the phantom limb and phantom limb pain and the rubber hand illusion, we replicated in VR. And this is also a lot of research done by Mel Slater group in Barcelona for many years. So we know we use these triggers to induce the embodiment illusion to the participant. Then we get another group that we try to disembody it from the virtual avatar. So we did everything in reverse. We rendered the virtual body in a third person perspective. The movement was asynchronous with a physical movement that the participant was performing. And of course, we also provide asynchronous visual tactile feedbacks in order to break that illusion of embodiment. And lastly, when they were embodied or disembodied, then we entered the training part of the protocol where they had to do the motor imagery, motor observation training to train the BCI. In terms of inducing the illusion, so we used a questionnaire, the latest question that was available in the literature and used by many studies from Peck and Gonzalez Franco, which is the Avatar Embodiment Questionnaire. And what we have been found is that we could successfully induce the illusion. And for that, we ran actually two studies. One was with between groups, and the other was within subjects. And so there's a reason for that. I mean, in the first study, we had two groups doing one embodied, one disembodied, but then given the variability that we might have cases that we might put participants that they had a very good and vivid imagery in the non-embodied group, and then it will be an outlier. And then we might have people that they are really bad on motor imagery, they have no vivid imagery, and they go to the embodied group. And we had small sample size, relatively small sample size per group, so it was 30 participants per group. So then we did another study where we did a within subject design, same participant, another group, same participant, different both conditions. And we ended up having around 28 subjects for that study. So to make the long story short, we have successfully induced the illusion. So we are sure that we can use this tool, we have a group of participants that they were embodied, a group of participants that were not embodied. Both around the BCI training. And nonetheless, what we found in terms of ERD and
No,
classification
no, just a
accuracy,
gentle reminder. Sorry for interrupting.
yeah,
Try to wrap up in the next 10 minutes. Okay?
okay, yes, it's I have 2 slides left. I'm done. So I'm closing with this. So this is negative results basically. So we haven't managed to see any differences between the embodied and the non-embodied conditions, both in ERD and classification accuracy, which we wouldn't expect that. Of course, this is ongoing work, and we have recruited more participants to increase a little bit our sample size and the power in our analysis. Nonetheless, it's quite important. What we hypothesize is happening here is that in-task embodied feedback is enough to uh, to drive these increases in ERD and BCI classification accuracy. So by doing embodied training in BCI is enough, and no prior embodiment is necessary. So it's either washed out, although it's right after the embodied training, or embodiment. It's not like something like a binary thing, like you're either embodied or embodied, but then maybe embodiment is changing over time uh, during the interaction that they have with the avatar. Um, and then there's also this bias where, okay, they know that they're a non-embodied group because they're outside of the visual body. Then they get a questionnaire being asked about the embodiment of the visual avatar. So they will be more biased on answering towards the one side or the other. So this is still ongoing research. Nonetheless, it's quite interesting. It's positive results for us because if we don't have to prior someone with embodied feedback before the BCI training, is good news because we couldn't be doing this with patients that they lack volitional movement. So if we can passively provide them with the motor imagery and motor observation, what we call the embodied feedback in first person perspective, and it's enough to induce these changes, it's far better than having to do a priming session where we induce them to the avatar. And I come to the conclusion, just all this time, just for some take home messages, that we've seen a consistent effect so far of the embodied feedback from basically from our research the last 10 years, but also we kind of see of the corpus of the BCI literature that's quite consistent, as we see induced changes on brain activity as we've seen in both EEG and fMRI. We've seen changes that VR is affecting also the BCI performance and the perceived user experience. Now, VR doesn't create neuroplasticity by itself, it rather facilitates it by providing this multi-sensory and embodied feedback. So this is a quite extremely important tool for us as researchers, given that we can use it uh, for simulating and inducing physiological responses that we could potentially drive neuroplastic changes in the future. So VR is the best test bed, as we say, for psychophysics. For it also provides this Hebbian learning, where we need to engage areas in the brain and encourage neuroplastic changes between different networks, and having these closed loop feedback models where we can see in general where the environment is actually modulating brain activity. We don't change only behavior with VR, we also induce changes in terms of brain activity. And so far, we've seen with the clinical studies that we run, of course, we don't have a huge body of patients um, compared to other studies, admittedly, but it's really difficult to recruit and sustain chronic patients in the chronic phase and increase the sample sizes. Nonetheless, we try to have, given the variability that we have in the literature, we try to keep our protocol the same across all these 10 years and try to have more evidence about the impact. So far, we see that there's a potential in driving motor recovery with the embodied VR feedback. Again, as I said, not only from our research, but also from all the corpus of the BCI literature that we see so far. Again, this VR research in BCI is quite young, relatively young, as I showed you earlier, within the last 10 years. So I'm anticipating if we can deliver such a realistic stimulus and feedback uh, to participants with the with version 1 or version 2 of VR that we have, that is still a little bit uh, uh, it's not it's a little bit how should I call it, not the I mean we can really trick the brain with current technology of version 1 and version 2 of VR systems that we have. Imagine that we can do in 10 years from now, okay, or 20 years from now. So VR could be also almost indistinguishable from actual reality. So that could actually quite change the way that we see how we can drive neuroplasticity. So we can actually um, uh, we go beyond this primitive. If this primitive technology that we have today can induce these changes, imagine what we can do in 10 years from now. That's the bottom line, basically what I'm trying to say. So this is, of course, this is work is supported first and foremost by the tears and the sweat of my students, and the national and European funding across all these years. And with this, I would like to thank you so much for your attention, and I will be happy to answer your questions. Thank you.
Thank you very much, Thanos, for these very interesting results. We can take now some questions from the audience. I think the best way to organize this is please use the React button at the Zoom menu at the bottom of your screen, and then raise hand, and then I will just give to the next person that wants to ask something. In the meantime, while you're doing that, maybe I can break the ice with a question to Thanos, being the devil's advocate a little bit. So, Thanos, as you know, we do very similar work in neurorehabilitation, but in my work, we mostly use functional electrical stimulation, maybe coupled also with orthotic devices, which effectively create the movement on the paretic limb of the patient itself instead of projecting a virtual hand like you do in your work. So my question is, isn't it better in terms of embodiment, agency, and ownership, which is what you're trying to induce with the virtual reality feedback?
To use the actual limb.
Yeah, why not use the actual limb, right?
Okay. Well, it's a fair question. It makes sense because as I see, I show your study right here. I don't know if you can, if I'm still sharing. So it kind of makes sense what you're saying. Nonetheless, so uh, uh, our hypothesis is this. So initially, most of the patients they are suffering from high levels of flaccidity or spasticity. So the hand is deformed. Um, so besides the fact that we can, render a movement that is, it's kind of gives the feedback of more healthy action, and we try to drive a visual feedback of the correct uh, motor, let's say, motor trajectory to induce a more healthy motor learning. Let's assume that I would accept that the intention and movement of the actual limb is far better. Although I think that the combination of two, I think, is the best solution in this case. Nonetheless, the benefits that we have by rendering a virtual environment is that we have, in terms of the task itself, because we live outside. That's why I said this is a holistic approach. We don't have a BCI approach on design when designing a rehabilitation system. We try to bring, of course, as much knowledge from occupational therapy as we can, and also physical therapy, and that means that we need to have ecologically valid tasks and training, which is to date, I think the best test bed to do that is a virtual environment. So we need to train activities of daily living of patients. So the best way to do this is inside a virtual environment. We can render any type of scenario we want to do. So I would argue that it's mainly for in using the ecological validity of the task, and also providing a more positive feedback that could try to reduce also the chances of compensatory movements and compensatory actions of the patient, because most of the times they have the tendency to move the trunk and the shoulder, um, by providing this more healthy feedback inside the visual environment. Of course, the truth is always in the middle. There's not absolute winner in this kind of cases. It's an active and ongoing research, but I would think that just providing the feedback, visual feedback of the paretic arm, I would say is not just enough. And especially for just flexion and extension actions that you can do very little, and the degrees of freedom that you have also are very few. So that's my main argument in your in that in that
Thank you.
comment.
Well, I will give you that indeed the FPS-induced movements tend to be very clumsy, very coarse, especially the more functional you're trying to make the task. That's why we're trying now to somehow constrain it with orthotic devices, but then that's at the expense of the ecological validity, as we call it. It doesn't look so much like your hand anymore if there are robotic devices. Anyway, yeah, as you say, I
I
agree.
know
Probably
everything is a
needs
matter
more
of
time.
trade-off. Everything is a matter of trade-off. So you're changing something from one side, you're losing from another side. So you're reducing. You want to have this support. You're reducing ecological validity. You increase ecological validity, virtual environment. You have less, maybe some cases of proprioception and haptic feedback, and so on and so forth. So it's still, yeah, it's still a big discussion.
All right.
Uh,
Okay,
so
is there another question? Please,
yeah,
please go ahead.
yeah. Just to, in your defense, I have to say also that when we see the clinical outcomes from all the BCI studies in the literature, we see that those that they have the biggest effect in terms of clinical skills are those with FES mainly.
Mhm.
Um, so I think, yeah, the way to go is for sure employing neuromodulation. Yeah, so I think a hybrid approach would be the best in this case.
Right, I see. Well, I have another question. It has to do mostly with classification accuracy, right? So normally in the traditional assistive technology BCI that we have mostly been doing is of this 20, 25 years of the field, accuracy is very important. However, what I see in our data is that it doesn't seem to be as important in the context of neurorehabilitation. And just to be clear, it is of course important. Without above chance accuracy, you don't have the contingency between efference and afference, and the existence of VCI wouldn't make sense. But what I mean is that, for instance, in the data I have, that these three different studies, never have I gotten a significant correlation between the clinical outcome, the improvement of Gullmeyer, and the classification accuracy. To put it more simply, the best performing in terms of motor imagery classification subjects were not necessarily the ones that recovered better. And since I see in some of your results, you insist a lot in that, like to show how the VR feedback made the ERDs deeper and make the classification accuracy better, okay, fine, but does do we really expect that to also yield better clinical outcome? Do you have any insights on this
Yeah,
area?
well, it's a very good comment because in this case, what I'm assuming is happening. So you see more of so it's more of in your feedback thing. So they are training the the brain patterns of the feature that you're selecting, but so that could result to some clinical positive clinical outcomes. But yet again, yeah, it will result. I mean, it will be easier because it's more the way you say it is more like it sounds more like in your feedback than a PCI. So uh, they are doing mental practice or motor intention. You see clinical changes, but then your BCI does. So either your BCI is not able to capture this change, um, and the your feedback loop itself, it's the one that helps the so it's not the closed yeah it's I don't know if it's the closed loop itself that it did. I mean that's a really bad thing to say for a BCI thing, but I don't know if it's a closed loop component that made the change or the the mental practice itself. uh, so and again with patients, I don't know, again your data, you might have a huge variability where the lesion is the clinical profile, so it might be reflected differently in different
My theory is
patients.
that, which I have not proven, of course, but the theory is that the closed loop component matters. And actually, the way we have controlled our trials is we have the same exact intervention, but we simply break the contingency, so the closed loop component, by providing fake FES simulation for it that is not coupled to the sensory motor events. So my theory is that you need to have above chance accuracy, otherwise you don't have the effect of the BCI. But as long as you have it, so let's say as long as you are at 60, 65%, 70% maybe better of accuracy, then the added value of this 65 or 70% being 80 or 90 is not so important anymore. Then probably other factors, as you said, the type of lesion or the motivation of the patient or whatever else, is probably starts being more important than the accuracy. So that's just an assumption.
Yeah, but I wouldn't totally dismiss the importance of the accuracy, because on the end of the day, you're interfacing them with a training task. So if their performance with a training task is problematic, that will affect the learning process, as we talked earlier. So I really, and again, I don't know in these cases that you're referring to, if the training task, if it was a training task or it was the FES, by triggering the FES. But if there's a task involved that it's, let's say, similarly to what they will be asked to do in an occupational therapy or physical therapy session, I think it's quite important to have a very accurate communication between the intention and the tip classification outcome that you might have, because then they're not performing the task, which is driven by the knowledge of the design task is driven by the clinicians. That's important. We don't just do, as I said, we want to have this approach where we want to fetch the knowledge of the BCI task from the clinic and not from the BCI world. So in our case, since we're interfacing them with an actual task, an embodied task that we have to perform in a virtual environment, this disruption, I think it will be also be reflected later to the clinical outcome. It will propagate to the clinical outcome, most likely.
We'll need to get, as you said, more data. As long as our
I mean, always,
like
that's the
20
major,
or 30%.
yeah, I mean, that's the major limitation at the moment. I'm sad to say that it's not very easy, at least for us to get a huge amount of data in a very short time. So, and if we do meta-analysis, still we have this variability of different protocols, different systems used, different inclusion and exclusion criteria. So it doesn't get any better either with meta-analysis. So hopefully, I hope that also the community will converge to a more standardized approaches. So that will allow us to have this multi-site, multi-clinical results where we can easily compare results from restorative BCI studies. I think we also talked about it in the last BCI, I think a couple of BCI meetings in the past, but that was one of the major limitations that we have. So, yeah.
Any other question?
The main story I wanted to say today, I don't know if it was confusing, was mostly the story of how we integrate the VR and why VR is important, and why we made that choice on using VR for training, given the impact that could have in from a psychophysics perspective. So.
So let me ask one last question on my side, and then we can close. I noticed that in the beginning, you said that the main end user group of this kind of rehabilitation protocols are people that are very severely affected, right? So with no movement at all, which is fine. I mean, that's the obvious scenario where the BCI makes sense compared, for instance, to triggering the feedback with EMG, if there is residual movement or something else, or just with the therapist, therapist queue. But do you think that's the whole story? So is this what we are trying to do? Just replace the queue for people that have no other ways to initiate and show their intention to move. Do you have any insight on that?
Well, I understand what you're saying. So, but the I quite highlight this component. I'm quite biased by a previous study that we have run with patients that they had some residual movement and they could also volitionally move their hands, and they had EMG that we can easily detect. And we had a set of patients that they controlled the virtual arm with EMG and then with the BCI through EEG. What we've seen is that the patients that they had better prognostic with that had residual uh, EMG uh, signals induced, we could see that those with a better profile they did worse in the BCI, and those that the worst profile they did better in the BCI. That means that we actually impairing them. So we reduce the communication bandwidth of someone that could might as well use an EMG interface, and we reduce the communication bandwidth with a more an unreliable EEG BCI system, and that resulted in worse performance than those that they have a worse prognostic, no active movement, and the only window of communication was the BCI. In this case, it was in those cases we increased the bandwidth of communication with the system, and those they were the ones that they were mostly um, showed increase um, accuracy on the BCI. In mind, that's why I mainly the way I see it is that the biggest impact, the biggest effect will be for those that they lack the the volitional movement. It's the only window with therapy by utilizing the BCI.
In our latest data, we see that we have the best effect to the subgroup that is mostly affected, which makes sense according also what you say. All right. So with that, I think we can close. Thank you very much, Thanos.
Thank you so much for your
Just to
time.
tell everybody that in a month's time, on 12th of November, we're going to have in the same BCI and seminar series, Professor Damien Coyle talking about his work. I'm going to advertise this shortly. Thank you very much, everybody. Thank you, Thanos.
Thank you.
Bye bye.
Bye bye. Ciao.